My laboratory has been interested for many years in trying to find selective therapies against KRAS mutant cancers, specifically lung adenocarcinoma and pancreatic ductal adenocarcinoma, pancreatic tumors. So what I presented are our efforts using genetically engineered mouse models to try to identify targets that are therapeutically effective, okay? Because in industry, I think now, developing a lot of inhibitors against many targets, but we still have to understand, have a better understanding of how the KRAS mutant oncogene signal to be able to be a little bit more successful in the clinic. Many of the studies that have been published thus far with genetically engineered mouse models, what they target is the initiation process. In other words, they eliminate the target or inactivate the target at the same time then the oncogene is expressed. So this is not what you find in the clinic. In the clinic, people already unfortunately come with tumors, and not only tumors, very advanced tumors. So now what we have developed is a next generation of GEM models in which we induce the tumor with one recombinase system, the FRT flipase system, and then once the tumor has been formed, and obviously you can have mice with relatively small tumors or mice with very large tumors, then we eliminate the target using another recombinase system, the most commonly used system, the KRAS system, which is more efficient. And then we determine what is the therapeutic benefit derived from eliminating that target, not during the initiation process, but in an already formed and many times very advanced and aggressive tumor. So we think that that data, those results, are much more applicable to a clinical setting than just inhibiting initiation of tumor development. I've been in research long enough to not like to predict what is going to happen. I mean, look at immunotherapy. Who would have predicted the big success in melanoma? On the other side, the negative side, with just 3-4 years ago, that we really learned about tumor heterogeneity. So I don't like to predict. The only thing I can tell you for sure is we will be better off in 5 years than we are now. But how much, that is not for me to say. Combination therapies are a must. I mean, anybody that sees the complexity of the cancer genomes, I think will be a fool thinking that just a single drug can cure it, okay? The problem with combination therapies is not so much combination therapy, but the cumulative toxicities. I mean, right now, probably there are enough drugs to block 5-6 pathways that probably we are in a position to block tumor progression and even induce very effective tumor regression. But these drug combinations cannot be used because they are too toxic. There is what we call cumulative toxicity. A drug is a little bit toxic, 2 drugs more toxic, 3 drugs probably too toxic. So obviously one of the areas is to develop drugs that are less toxic, and this is the realm of the medicinal chemist. But also we, biologists, we need to identify targets that are only relevant for the tumor signaling, the oncogenic signaling, and not relevant at all for the normal counterpart. So then we could have drugs that have minimal, if any, toxicity. And then once we have that, then you can use combinations of 5 or 6 drugs. But until we are able to, either by making better drugs or by selecting better targets, reduce the toxicity of a single drug, each by themselves, until then we cannot combine them, because if we combine them, we just reach intolerable toxicities and patients just cannot take it. Success is going to be tumor by tumor. I mean, Sometimes there will be major advances in a particular tumor type, as we have seen with metastatic melanoma and immunotherapy. Clearly we're going, as I was saying before, we are going to make progress. But how fast and in which tumor type, I think is very difficult to predict. What is very important is that clinical work talks a lot to experimental work and vice versa. I mean, this idea of going from the lab to the clinic and from the clinic to the lab is very important, that the information is in both directions, because only studying clinical samples we will be able to know what are the relevant mutations in real tumors. But then you cannot experiment with humans. You need to take these tumors, put them back in the lab, either in with PDX models or organoids or cell culture, and then, or maybe making new third generation genetically engineered models. So experimental systems that really mimic what is going on in the clinic. Here you do your research, and once you get good results, then you send them back to the clinic and see whether these results really have a benefit for the patients. But it has to be a very fluid communication between the real world, the clinical samples, the patients, and the experimental world, which is primarily mouse, although obviously I don't exclude other model systems. But these days is primarily mouse, or as I said, organoid systems that are also very useful. Thus far is the best EACR meeting I have attended. I have interest in all of them. Some of them is just curiosity, immunotherapy, because right now we are not working on that. Certainly drug resistance is also very important, because it's a fact that we all have to deal with. So, I mean, in general, I find all the sessions I have attended thus far very interesting.